And I think that, this example also shows us what happens with the OCTs in diabetic macular edema. If you recall, the DCRNet published a study in which they demonstrated that OCT thickness really did not correlate well with visual acuity in patients with diabetes. And the same issue. The issue is that, what determines your visual acuity isn't necessarily that you have cystic changes here, is how, what the health of your photoreceptor layer is doing. And I think that's going to be important in terms of monitoring these patients. And I'm using the same type of strategy to monitor my DME patients. Do I really need to be aggressive about getting rid of all the macular edema? I don't know. We'll find out. And this is something that we've proposed to the network to try and help us evaluate these patients, and perhaps use these type of systems to determine when we need to intervene or not, because you may be able to detect a decrease in functional activity over time, especially because we're able to reproduce the studies and monitor these people longitudinally. Again, the OCT provides me with a fantastic anatomical view of what's happening with the tissue, but again, it doesn't give me an indication of what the functional status of the eye, of the retina is in these individuals. Let me just go, from a study standpoint, for those of you who have heard Alan Bird and Frank Holtz and them talk about autofluorescence, and I want you to see how nice you can correlate the activity. What the dogma is that if you have these rings of hyperfluorescence in patients with RP, typically what that implies is that that's a border or a zone of functional or more functional photoreceptors versus areas that are more atrophic. And you can demonstrate this with your MP1. Here again, the OCT shows us a very nice view of the photoreceptor layer that's still remaining in these eyes. It's wiped out here, which in a sense correlates nicely to the area. But again, you don't know what the functional status is of the tissue in the middle. Okay, and when you do the MP1, what you find is that they both have the ring, but now I'm more concerned because I'm starting to see some more central defects in this eye. So again, it helps me, in a sense, try and prepare the patient for the fact that, if the left eye has got changes now occurring in the middle, then the odds are that perhaps in the future you may face the same problem. And I think just from a discussion of a prognostic standpoint, it's helped me, relate this to the patients, so like that they understand what's happening, and it helps me understand why patients who have been stable for a long time all of a sudden come in complaining, and my fluorescein, my visual field, and all my other testing look very stable, and now I'm able to see that in fact something is beginning to happen closer to the fovea, and that's and the patient is complaining of those type of changes for that reason. Now, again, when you see changes on the OCT, this is a patient that's actually very interesting. She's a diabetic, okay, and on the OCT we found changes from a lamellar hole. Okay, when do you decide you want to do something? Obviously, the vision is important, but watch what's happening. This patient has some hard exudates and diabetic retinopathy, and you can see that there's been a disruption in the photoreceptor layer here from previous macular edema. And in fact, before we treated this patient, she did in fact have some hard exudates here. So not surprisingly, this individual has a complaint in that eye, and I'll show you the MP1. But at the same time, you can see this OCT. You can see an epiretinal membrane here and a lamellar hole, maybe some edema, some hard exudates from the diabetes. What do you do about this patient? Again, another example of how the anatomical changes here really don't correlate with the function of the tissue below that. You can see in this left eye, although there is a reduction centrally where you have the lamellar hole, the patient is still doing well because the vision the sensitivity is better right around that. So in this subject, because of the problem that she's had in the other eye, specifically, the central scotoma from a hard exudate that improved and cleared, I would monitor that patient and wouldn't want to do anything surgical on her unless she started becoming more symptomatic. But again, I think, this is going to be a very sensitive way to be able to confirm any changes that the patients may come back complaining. What I did with this patient, I sent her home with an Amsler grid. Obviously told her to make sure she takes care of her blood sugar. She doesn't have the same problem here with treating her diabetic retinopathy. But in the left eye where she's got that obvious macular traction, we're monitoring her at home with the Amsler, and then she's to come back intermittently for evaluation with the microperimetry unit. Now this is an interesting patient. For those of you who do retina surgery, quite often, and this is a more obvious case, but I wanted to use this one just because it drives home a very important message, and that is you do surgery on a patient. Anatomically, the OCT looks fantastic, but then the vision's not good. This is a patient who had a macular hole, and the pre-op vision was about 2400. Okay, the post-op vision, as you can see, count fingers, and this is months after we did the surgery. So what do we find? Well, you can see the right eye everything looks great. The photoreceptor layer is intact. You get a nice anatomical central macular region. The left eye, you can see, has an intact photoreceptor layer across, but you can see that there's some anatomical changes on the surface of the retina. Okay, there appears to be some atrophy of the nerve fiber layer here. And unfortunately, pre-op, it's not something, I didn't pick that up. Okay, so we were able to do the surgery. We closed the macular hole, as you can see, but you can see what the problem is here. She's got, this individual has a very important loss of function here, although from the OCT appearance, the photoreceptor layer is intact. So what's probably happening in this patient, and I have not performed a multifocal ERG to test this, but it appears that the nerve fiber layer is gone here. So the photoreceptors are here, but they're not connected, and it's not surprising that the patient is having these complaints. So again, and I can give you multiple examples. This is a very interesting case, that presented with to one of my associates with non-specific complaints. I woke up this morning and I just do not see right out of this left eye. And my associate took a history. There was really nothing there. There was nothing that he could see at the time. Maybe some non-specific changes in the choroid, but nothing else. No vitreous cell, no anterior segment cell. The other eye was normal. 4 days later, the patient come back with a very important drop of vision. And now you look at her, and he did an autofluorescence, and you can see that there's an obvious difference in the autofluorescence pattern here. But again, what does that mean functionally? Should that patient be 20/80 or not? And how are you going to monitor this patient's treatment? Unfortunately, this patient was seen just recently, but you can see what the MP1 looks like in this patient. Here's the OCT on the right, and then this is the affected eye. You can see that there are some areas of disruption in the normal anatomy of the photoreceptor layer and RPE complex here. But again, what does that mean functionally? The patient's 20/80, 2200. Why is the patient 2200? That's pretty significant reduction in activity there. Can you measure it with something? Yes, you can. Look at how impressive this woman's macular sensitivity is. Normal in this eye, so obviously it correlates with what we see. We don't see anything going on with that right eye, but the left eye, as you can see, she's had a very significant drop in macular sensitivity here. Now, she's been worked up. She's being treated on steroids, and actually she's coming in next week, and we'll have a way for us to begin to see if our therapy and our intervention is functioning. So in summary, OCT and the new imaging technology has really improved in our ability to see in high definition what the anatomical structures in the retina are doing. Unfortunately, that